So on now to the next section, which is presenting the details of history and examination. Now these key criteria state here that the details of the history and examination should be concise, accurate, well structured, and address the key points. At the same time, one should clearly make the link between the history and examination, and also be careful to avoid extensive and irrelevant details. Now the BMA Medical Students Committee also go into a bit of detail on this. They state that this is a summary of the patient's story, and one should also provide the relevant questions and a systems review. And at the same time, avoid extensive abbreviations and irrelevant medical terminology. And just a final note, one should be careful not to forget the social history. Some examiners may be particularly interested in this and how the condition affects the patient's life, and this may be more relevant with some conditions than with others. Okay, and now just some tips on how to answer questions around general disease knowledge. Watch the following segment and consider some of the plus points and the minus points of the student's answer.
Okay, so you mentioned ankylosing spondylitis. What can you tell me about that?
You get back pain from it. So you get lower back pain, and it's sort of like an arthritis. And there's an HLA involvement. And it's rheumatoid negative as well.
Now you can tell the student knows something about ankylosing spondylitis, however it's coming across awkward and jumbled. One of the textbooks on clinical examinations emphasises the importance of knowing definitions. Even though today problem-based learning is fast replacing rote learning, not knowing a simple definition is considered by many examiners as an own goal. Also, it psychologically leaves a bad first impression.
Okay, so you mentioned ankylosing spondylitis. Just tell me about that, please.
It's one of the seronegative spondyloarthropathies, which is basically a group of rheumatoid negative and inflammatory arthropathies that affect axial and sacroiliac joints, and ANK-SPOND in particular is a chronic arthropathy associated with HLA-B27, which typically affects young men, and it presents as a lower back pain, but may become more disabling over the years.
So you see the difference here. Provided you know your stuff, definitions are easy once you figure out a pattern. You mentioned something about the etiology or associations, along with who gets it and how it presents. Now for the investigations, the ISCE pack mentions that students should have a clear understanding of key investigations, along with their interpretations. Also, one should know something about sensitivity, specificity, and approximate costs. Now, a couple of other pieces of advice given by one of the students was that one needs to be aware of the clinical setting. That, for example, one doctor in the emergency department setting may request different investigations from that which a general practitioner may request. One of the other tips was that the student should realize the comorbidities which may affect the ability of the patient to carry out certain investigations. So, for example, a person with advanced bilateral knee osteoarthritis may find it very difficult to carry out an exercise test. Watch the following clip.
Okay, so just saying on the subject of renal failure, how would you follow up a possible cause?
Renal biopsy. So you look at small kidneys and large cortexes.
Okay, but is that the first thing you do though?
No, of course not. I do bloods first.
Okay.
Yeah, and then I'd do USANEs to look for urea and creatinine, and they could also be anemic as well because EPO production may be affected, and then a full blood count as well, maybe.
Another student tip when it comes to the investigations is to classify them similarly to how we discussed the classification of etiologies. Now, one way may be to consider, first of all, the bedside or less invasive investigations. So, for example, you could include within this urinalysis, cultures, various blood tests, and also things like ECGs. One would then move on to imaging modalities, starting with the less invasive methods such as plain films and ultrasound scans, and progressively moving on to CT scans and even endoscopies. Finally, one would consider special modalities, for example, biopsies. Now, another method may be to divide investigations into the objective that one wishes to attain from them. So you could start off with those investigations used to arrive at a diagnosis, then moving on to investigations used to stage the disease, and also you could add in those investigations to do with determining the underlying causes or exacerbating factors, and also consider those investigations used to monitor the prognosis of the disease.
So staying on the subject of renal failure, how would you go about following up a possible cause?
Well, first of all, I'd like to confirm the renal failure and see what could be the cause. Then to do that, at the bedside, I do a urine dipstick analysis, and I'd be looking for blood and protein in that. Then I could do a blood pressure, see how the blood pressure control is. And then I'd move on to blood tests that I do, and I do using these, and I'd be looking for urea and creatinine, see if they're elevated. And then also potassium levels, which can complicate renal failure. And then in the full blood count, I'd be looking for anemia, which might need to be treated. And then I can move on to, and then I do glucose as well, see if they're diabetic or not, which may complicate the renal failure. And then if they are, I could do HbA1c to see how their long-term glucose control may be affecting their renal failure. And then something like cholesterol you can see, which may imply renal artery stenosis. And then I can move on to imaging modalities such as ultrasound, and then I'll be looking to see if the size of the kidneys, if they're enlarged or small. And then in the ultrasound you can also check for obstruction, which may cause post-renal failure. And then X-rays and contrast enhanced X-rays like IBUs as well may show up stones, which may cause post-renal failure.
Okay, so as a GP, how would you go about investigating possible cause?
As a GP, you could do urine dipstick analysis, again looking for blood and protein, and also blood pressure to see what the blood pressure control is like. And then you could send off bloods, checking things like the USNEs, full blood count, potassium even,